This is case of the day, and today is the 135th case, a tale of two posterior segment left upper lobe lung masses, and you can actually see them here. Before I start, I'd like to thank Dr. Rahul Dudal. He is at Ashwini Hospital in the Navy. He came to see me today. It was nice meeting up. But as he reminded me, it was his query in one of the posts that I had done, I think at ctchestreview.com, that made me do a video which I then put up on YouTube, and it actually started the Case of the Day series, which now has taken a life of its own. So thank you, Rahul, and thank you for that vacuum tube. So we look at two cases, and the last time I did that was case 13, just a couple months after I had started, or actually within the month that I had started, where I had these two patients with lung lesions. The 42-year-old turned out to be TB, and these lesions regressed on follow-up. But this patient, and I presented this patient again last month, at that time was treated for TB, didn't improve, is actually non-infectious granulomatous disease, waxing, waning, and we're still looking for an answer. So the first case is a 79-year-old, came for a CT-guided biopsy. A CT chest shows a spiculated lobulated mass. It's tethering the major fissure, and this is malignant unless proven otherwise. The second case is a 72-year-old non-smoker who came for a biopsy, and the PET here shows a mass. It was involving the left upper lobe bronchus with post-obstructive atelectasis, and this was to be biopsied. And you can see on the contrast study a faint outline of the margins of the lesion separate from the atelectasis. The first patient was a smoker, 79. I hadn't seen the patient, so I called the patient before the biopsy on a separate day and made the patient prone, and also looked at the patient to make sure that the patient wasn't frail, or as we sometimes say in Hindi, khakru patient, somebody who, if they have a complication, we would land up with a problem. But the patient was otherwise hale and hearty. And while this seems to be straight into the lesion, it's transfissural, and that increases the chance of a pneumothorax. So my plan was to go further superiorly and then, if necessarily, angulate down. The second patient is simple. On the PET, you can see the area of uptake. So the idea was to just take an anterior approach and go straight down. So the first patient, I used an 18 gauge bar, 20 millimeter throw, and it's along the 15 centimeter gun. And as you can see, once I started, there was very little, just the superior part of the nodule visible. And then I had to start angulating out of plane, which means you just have to keep at the skin surface, directing the needle more inferiorly, which I did. And so that is out of plane angulation without gantry angulation. And once I was inside, deployed the gun and biopsied it. So otherwise quite straightforward. There were no other issues. A little bit of bleeding, that's the rapid rollover, no pneumothorax, and 6 minutes follow-up was absolutely fine, and the patient went home after a couple of hours. In the next patient, when I looked at the plane scan, and while I knew that I had to biopsy this area, I just wanted to be absolutely sure. So I gave contrast again, and on the venous phase, I could see the margins very well. Then it was straightforward, 18 gauge bar, 20 millimeter throw straight. And so at this point, I will always give 10 millimeters of saline. It helps with pain control. And there's been one article that suggests that it also reduces the chance of pneumothorax. Not that that was a problem here, because I'm not even going through aerated lung. So straight in, deployed the gun, biopsied it. It took about 9 minutes, a little bit of air because of the necrotic component there. And I didn't do a rapid rollover, 5 minutes follow-up, no other issues, and the patient went home after an hour and a half. So both patients had no complications. So just to show these in perspective, two different presentations but the same segment, one with a prone out of plane angulation, the other supine straighten. Both turned out to be adenocarcinoma, and the reports came in the afternoon today. In case you want to learn more about CT chest biopsies, I've got a whole bunch of cases up at ctbiopsy.com, and this is constantly getting updated in case you're interested. But the lesson here is that each lung lesion is unique, and depending on the specific location, the patient habitus, and the size of the lesion, you will need a unique plan to biopsy each of these lesions. Uh, that's the Rat Protect in January, my WhatsApp channel. Thank you so much for viewing this.